Recording. We're live. All right, Mary's going to start us off.
Okay. Well, welcome to Sound Mouse Question and Answers. We're really excited that you guys were able to be here with us today and to take the time out of your busy day to help learn more information about speech, language, or myofunctional disorders. Before we begin, we just want to tell you a little bit about each other here. My name is Mary Francis, and I'm a licensed speech pathologist and certified orofacialologist, and I've been practicing for 22 years. When I stumbled upon orofacialology, I started to realize that it was the missing link to my speech therapy. So it really goes hand in hand with what we do, and it helps me make more gains quicker and faster with my patients.
Awesome. And I'm Elaina. I'm a registered dental hygienist, and I've been in the dental field for a little bit over a decade. Same with Mary. I realized myofunctional therapy was like the missing link to a lot of dental problems that my dental patients were having, and kind of dove into that world of airway. And we work great together because we have different educational backgrounds, even though we do the same thing with myofunctional therapy. Myofunctional therapy involves like a lot from the speech side and the dental side. So working together, we really see both of those perspectives.
Yeah, it's super helpful.
We learn a lot from each other. I learn a lot from her.
I learn a lot from Elaina too. Just a quick disclaimer here. Any context expressed are the views and opinions of these therapists and are for educational purposes only. You should not rely on the information as a substitute for, nor does it replace professional medical device, diagnosis, or treatment. Because each person is unique, always consult with their healthcare providers.
Stop, throw that out there.
Yeah, gotta throw it out there. All right, so Susan.
Start with Susan.
Okay, actually, the first thing I wanted to ask you to do is just slow down a little bit when you were going over exactly what your occupations, a little bit about your background, because frankly, you almost need to go through speech therapy to say some of the words.
That's true.
And I always have trouble then remembering exactly what they are when I'm trying to tell people about this. I kind of understand what it is you do, but to try to summarize it so I can pass this along to other people, because I'm really, even from my own experience, I'm understanding how important and foundational this work is, and we're just like so missing out. I've worked with a osteopathic doctor that feels like the whole functional medicine space is really missing out on a huge element.
100%. Yeah.
Oh, yeah.
Right. So if you could say exactly what you said, oral, myofacial.
Okay.
So yeah, a lot of my own family members too are like, wait, what do you do? So I like to explain it like breaking down the word, right? So orofacial, oral means mouth, facial means our face. Myofunctional, myo is a Latin origin of the word muscle, and therapy meaning, working on, like, think of like physical therapy. So orofacial, myofunctional therapy. What we do, we condition and strengthen the muscles of our orofacial complex, so tongue, face, to work on our functions that our face and our tongue do. What are those? Breathing, speaking, chewing, swallowing, all of those things that involve the functions of, basically here up. So if you're thinking of like functions of like, think of a physical therapist who works on someone's like knee. What are the functions of a knee? Well, you need to walk, you need to run, you need to stand up and down. So we do that, just the functions of here up. Does that make a little more sense?
Yes, what you were doing, I kind of understood better. And it was really the term. And I think what really confuses me is facial, because that means that area of your body.
Yes.
It's not just the muscles and the ligaments and these connective tissue. I mean, all the different types of connective tissue, because one of those parts of the connective tissue is the fascia.
Yes.
Right.
Yes. Yeah. So
I think the problem is the facial fascial
Yeah, a lot of people get it
Okay.
mixed up with like myofascial is a type of like massage therapy that like people who are myofascial therapists, those are usually massage therapists that work on the fascia.
Throughout the body.
Yeah, like so what we call body workers. So they're like hands-on. So people do get that mixed up with myofunctional, myofascial.
But they really do intermingle though, because
Yeah, 100%.
you have the fascia that goes from the tip of your
Tongue
tongue
to the tip of your
the tip of your
toe.
toes.
Right.
Yes.
Right.
We actually call that the deep frontal line fascia. And there, I don't know if you've seen that wonderful picture that's out there that shows it's like a sheet that is like from our tongue to our toes.
Mhm.
So it's all interconnected. You're completely right.
And yeah, and yes. And so I say, and when I started to actually realize as the doctor was working with helping me stretch out the tongue tie, doing some laser treatment with it too, just trying to, I could feel it down in my toes.
Yeah.
Really, it's just like so mind blowing.
Yeah, there's actually like research out there with kids that are like toe walkers. If you ever see kids like who walk on their toes, a lot of that has to do with that fascia and possible tongue tie connection there too. So yeah, all connected.
Some new emerging literature about that.
Yeah.
It should be wonderful.
But that's awesome that you're already kind of like in this.
It is, and it is helping me, but it's a slow process and it's been a little hit or miss. I originally started with one dentist and then moved to another dentist. But it still kind of feels disorganized in the sense of what do you do when? And I realize some of it's because it's very individual, and probably the older you get, the more complicated it gets. But it's trying to put some reason. I have had some interest in getting into health coaching, but through all my stuff, and there's a lot of other things out there too. But I've realized that this is critical. But how I'm doing some work too with have you heard of somatic experiencing?
I have.
It's like it's helps. It's often accompanies trauma work, but frankly, it's something that all of us trying to become more embodied again, because we're also in our heads and not what's going on with our body. But that's helping me have a little bit more bandwidth to realize the overwhelm element with all of this, and how even though all those different things help, you keep hitting this overwhelm thing until people start working on their capacity. But of course, some of it is getting this working and getting your airway working well, because that in itself is limiting your capacity to do. I'm very interested in how to kind of organize this and making this more accessible to people, and like even really basic things like just like I do mouth taping. In fact, that was like one of the first things that I did once I started realizing all this stuff was out here, and that I had a lot of catch up to. I'm dealing with it. One piece of it is the orthodontia injury, because I had those premolars.
Distracted.
Yeah. So my mouth was too small. So I'm very slowly expanding this out, having room for my tongue, getting flexibility. I can move my jaw around now. Before I couldn't move my jaw back and forth, and
Oh, excellent. Yeah. You're in good.
But I feel this is so important. As you said, like there is this growing community. Is how do we start, how do you roll this out? How do you present it so people aren't stuck in overwhelm? And given, of course, what we all just went through with the pandemic, this is a big.
And I want you to know that like in therapy, you might feel like it's overwhelmed, but what happens is once you start working on one thing, we start to peel back the layers and something else may show up. And then you're like, oh, now we have to address that too. And you just keep peeling back the layers until you start getting them all to function like correctly and together, and reintegrate. And plus, remember, for motor patterns, I think first off, any ages, 4 and above can do myofunctional therapy. And I don't think it's a matter of like, because, your age that's taking a long time. It's that you've had a lot of years of motor patterns, right? Of doing this one specific thing
You've been
over and over and
dysfunctional
over.
for this long.
So it's going to
You're
take
not
a little bit
Yeah, correct it.
to retrain
Yeah.
that neuromuscular pattern to redo it correctly. And so don't give up hope. You just are opening up each layer so that when you're all done, everything will be working, together.
Yeah, it's a journey, we say. It's a lot of airway stuff. It's a journey. It's usually multiple providers, like you see an osteopath, you see Dr. Bronson, all of that. And yeah, especially as you get older, just the longer, if you've been dysfunctional, then might take more to kind of rewind all of that. So,
Right.
but you're
But it's
great. You're
Yeah.
like you're on a perfect trajectory, and you're so aware of all of it. So you're ahead of most people out there.
Right. You are, definitely. And and sometimes it involves, when you also reach a plateau sometimes, or feel like it's really hard, sometimes it involves another provider. And we figure out, is it a body worker? Is it an osteo? Things like that. Like, something's not working. Let's figure out why. We may need to add somebody new to the mix. So that's really important.
I see that Jenny's on here now too, so I've been talking for a while. So
We'll come back, because I'm sure there's some other stuff you wanted to ask.
I mean, everybody, yeah, I'm sure you guys provide services for a wide range of needs.
Oh, welcome, Jenny.
Welcome.
Yeah, thank you. Hi, Preeti. I've been talking to you via email, but I have 2 boys, and they both go see Dr. Khan at Safe Haven, and so that's kind of where the referral came from. My son, my 3-year-old, he has a tongue tie, but it never affected his feeding. I don't think I mean, he has he has a little bit of a lisp. Like when he says monster, he'll say monster. So I don't know if that's considered a lisp, but I do realize that, like, getting the sound, like the tongue up, might be like a palate issue, who knows? But I mean, overall, he's pretty responsive. Like, he knows how to make requests as far as like what he wants and what he does not want. So that kind of minimizes the tantrum and his frustration, because he can like communicate. However, when I'd like to have more of a conversation with him too. Like, maybe he needs that extra nudge. Like, when I ask him a question, hey, how was school? What did you learn? He just kind of sits there, and then I'll have to ask, well, I know that's like a big question to ask, but I'll help him out and be like, did you play on the playground? And then he'll say, yes, I play with Ethan. But as far as that goes, there's not much description to his answers, which I'm sure you'll say it's normal for a 3-year-old. And so I don't know if in his case what he really needs, because he is communicating what he doesn't like, and that's all I ask. He's fully potty trained, he knows his ABCs and things like that, but yeah, what would you do in a situation like that?
Right. So when we're looking at, especially that age, right, we're still developing skills and things like that. And we expect these certain skills at that age. In order to look at that, we'd have to look at speech and language skills. It sounds like he has some difficulties with the R sound, and could be emerging. If it depends if he has it in some words, but not in others. So that would be articulation, right? We would be looking at his speech sounds, how he makes them, how intelligible he is for a 3-year-old, right? At 2, we need to be 50% intelligible. It's like a guess of what your 2-year-old's saying. At 3, about 70, 75. And then at 4, your 4-year-old's basically like a little adult in terms of their language and their articulation skills, and they should be understood about 90% of the time. So we would first look at, the speech sound system, how he makes the sounds, how he puts them all together. And then we take a look at language, and language assessment would look at his comprehension. Does he follow directions? Does he understand prepositions? Does he answer? Does he understand all the WH questions? Who, what doing, where, when, why, how, right? Then we also look at grammar, because at 3 years old, our grammar, it's called morphology, is starting to move forward and become more advanced. So we look at receptive language, understanding, And then we look at expressive, and that's looking at some of that grammar, his vocabulary. Is he understanding object functions? You know, there's a lot of things you look at. So when we do assessment for a child that age, because you're not really sure what he needs, we would look at just the entire umbrella. And then as we're doing the assessment, you can kind of gauge, you know, if we need to do further analysis of things. But that's what we would do for your child. If you're not really sure exactly what he needs, but you feel like you need something, we could take a look. And like I tell parents, like the worst case scenario is that I tell you your child is doing well. And here's some tricks to encourage, you know, the next level of language skills.
Yeah.
And
Okay. So in an evaluation, I guess. Oh, sorry, I thought it was. And then in an evaluation, I guess there's a level 1 and a level 2. Could you explain what's, I guess, administered in a level 1 and a 2 on a child?
For us, we look at how many different types of tests we have to use. So an articulation, a language test, there's vocabulary tests, morphology, myofunctional. If we're just looking at one area, then that would be a level 1. The level 2 is more in depth. And an example would be if we had an 8-year-old that couldn't say his S's. So we're going to look at articulation, but we also know that there's specific speech sounds and lisps that can go along with the myofunctional disorder. So we would also look at the myofunctional analysis for that person, that child. So that would be a level 2. That's what we consider level 2.
Okay, so
How much
myofunctional.
time and how many tests you're going to be getting.
Okay, I see. So level 1 just kind of encompasses the different areas that include myofunctional, like vocabulary, grammar,
Well,
and
everybody's
myofunctional.
different. Like a level 1 would be like just an articulation test, maybe, or just a language test. And then because we can do multiple things in my practice because we're speech and myofunctional and an RDH, we can do an array of different evaluations. A level 2 is basically 2 or more different types of tests. That's really how we try to break it down. But we do based on what they need. We can't determine until they walk in our door and we read your case history and we talk to the child even for a mere 5 minutes. And then we can determine, you know, do we need more or do we just need one assessment?
Okay, and myofunctional is
Myofunctional is
okay.
completely different. Myofunctional evaluation, we wouldn't do that for a 3-year-old. We would look at some of the skills they have for feeding and swallowing, but a myofunctional evaluation is basically for 4 and up. And that looks at the tongue, the jaw, and lips, the muscle function, feeding and swallowing, and then sound placement. And that's just one area.
Okay. So wow, feeding, I'm surprised you mentioned that, like at that age. Is that just like how they're like chewing, how they're putting things in their mouth and things like that? Okay.
Absolutely, because feeding skills develop from birth until 3 years of age. By 36 months, our preschoolers should be having a mature swallow, which is the backward swallow rather than the thrust. So usually, you know, the muscles of the mouth are the same muscles that you use for speaking and swallowing. So you can see a lot of things early on just in the development of the swallow.
Oh, okay.
And feeding skills. So drinking, swallowing, using a spoon, using utensils, being able to gather the bolus inside your mouth. We look at it all.
Okay.
Hopefully that helped.
Yeah.
Yeah.
And then let's see. I think your other is
That was her
okay.
that said that, yeah.
We're just reading out here the questions. Did you have any more questions about that?
I mean, which level? So you would start with level 1 then, for example, for a 3-year-old coming in to get evaluated.
It would depend on what the concerns the parent said. For example, here, tell me what your concerns are, and then I could tell you what level it will be.
Yeah, well, I mean, the list, the sound, it doesn't bother me too much. I mean, I feel like it might be one of those things, like how do you determine like he might grow out of it, right? And how much of it's this early intervention. But yeah, just more importantly, I guess extending his reach of vocabulary, his grammar, so that he can get more of the, like you said, the W's. Like if I ask him more of a descriptive answer, like who, what, when, where, how, that is not just yes. And that's it, right? Because I know there's so much going on in his head that he wants to express to us, and it would be nice to get that out of him, right? Because then I could know really what's going on in his day to day, so that I can help him. Like, oh, did something happen in school today? Did something happen on the playground? Was there something that upset you? Just so I can know from like a mother therapy son's perspective, like I can understand what happened. He's not with me for 8 hours a day, which is, I mean, I have to work, but I don't see what's going on. And so I can only go by like what he tells me. And then, I just want to dig deep sometimes, like, just to try, just so I can have, I guess, what's the word, a more deeper conversation with him, if that's even
Right.
possible as a toddler, but build a relationship, I guess, with him more.
And it sounds like you're already using some of the language strategies. I'll give you a couple here. So, first we have to look at he's 3, and sorry to say this, I'm a mother of boys. He's male. Like, how was your day? How was your day? Good. Like concise, short and concise. I know someone's going to probably rip me apart, but I am a mother of boys, and my 15 and 17-year-old give me one word.
That's what our husbands say too. How's work today? Good.
So, but we can try to encourage it, right? So you ask them, what is day, because they probably give you the itinerary. Like, we were painting today, we were painting dinosaurs. So what did you do today? I don't know. Did you do any painting today? Yes. Were you painting dinosaurs or, farm animals? So ask him questions, even though you know some of the answers, to allow him to be able to pull that information out to understand how to do that verbal turn taking of question, answer, right? So asking open-ended questions. If he doesn't readily give you information, provide 2 multiple choices. Like, what did you have for snack? And he's nothing. Then you'd say, did you have apples or oranges? Because he had one of them. And then, oh yeah, I had oranges. Okay. Did you eat a little bit, or did you eat a whole orange?
That's good.
And so asking him questions and giving him choices that you think he is likely to have done. And then that's great. So today you were at school, and you could recast, like, shortly in a couple sentences what his day was like, so that he starts to see some of that. But it is a lot to expect a 3-year-old to give you a itinerary detail of his entire school day.
Yeah, maybe I just have mom friends whose kids are just more chattier.
Oh,
you mean female?
No, they're boys. And he tells his mom like everything.
It's hard to compare.
Some is personality too.
Yeah,
I would definitely not compare anyone.
It's hard. We all do it, even though we know we're not supposed to, right? I have a 2-year-old, and I have friends with children the same age. So I was like, well, what is their kid doing? It's hard, but you can't always
see where his language development is. Maybe he's a little more advanced in his language skills, or has more vocabulary to give more details.
Okay.
Definitely. There's some good strategies to give you, like, right now, that you can do without leaving your house.
Okay. And then just a few more questions. I wasn't here for the introduction. Can you both introduce yourself?
Yes, we'll do it again. I'm Mary Frances Gonzalez, and I'm a licensed speech language pathologist and a certified oral facialmologist. And I've been practicing for 22 years. And oral facial myology, 8 years ago, basically changed the way that I practice. It makes me a better therapist, a better investigator, and I'm able to help more children and adults faster than I ever have been able to. It opens up.
Okay, so you work mostly with adults?
I do both. I do 15 months all the way to adults. And then Elaina here.
I am Elaina. I'm a registered dental hygienist. So all speech stuff goes to her. I'm a registered dental hygienist, but I'm also a myofunctional therapist. Most myofunctional therapists out there are usually a dental hygienist or speech language pathologist. But yeah, same as Mary, I found a lot of problems that my dental patients were having. I realized were the root cause were what we call myofunctional disorders. So I got, involved in this field, and then I got the lucky opportunity to work with her. She as my mentor, and she's been doing this longer than me, and we learn a lot from each other on the dental and the speech side together, which has been great.
Yeah, because there's a lot that we don't learn as speech language pathologists about structure, like the dental arches and the width of the palate and the way that the occlusion is, or what an open bite is. And so you learn that with myofunctional, but you don't really learn the nitty gritty like they do. So it was,
and same goes the other
yeah,
way around. So like working together, it's been amazing.
it allows us to really
Yeah.
get the big picture of every one of our patients, because it's not just looking from, language and speech and myo, it's, dental, speech, language, and myo. So for us, I think it's it's an awesome balance.
Yeah, because actually that reminds me, my son does have like I guess a crossbite, or it's an underbite, but the front goes behind the bottom.
Yeah,
And so yeah, he kind of does that clamp.
Okay.
Yeah.
So there's a 50-50 chance, I guess, when his new teeth come in that they'll grow in correctly, but I don't know if it's a bone thing, right? His like gums, or it could be just the way his teeth want to sit for now.
You want to expand on that?
Yeah. With the underbite, it's usually his skeletal structure
Mhm.
is causing that. A lot of
Yeah.
times it is genetic. I'm not sure if anyone else in your family kind of has that underbite. We call it class 3. Early intervention is really great for that. Seeing an orthodontist that specializes in early intervention with kids, usually to get expansion would be best, but definitely consult like a orthodontist who has experience in early intervention.
Which is really important that they can see children that young and treat them.
Yeah, kids are more like, anything when we're younger is easier to change, right? Like you heal faster, you're still growing, like everything's easier. It's when we get older, like things get harder. Like even just like in dental, when we tell people to get their wisdom teeth out, we're always like, do it as young as you can because you heal faster. And, it's the same with orthodontics and all of that stuff. When you're younger, the better.
Right.
Yeah. Okay. Yeah. Do you send any therapists then to the classrooms, like at their schools, daycares, or is it everything is in office? And how long is each therapy session?
Everything is in office here at this time. We haven't done any home visits or school visits, and majority of our sessions are 30 minutes. We do have 45-minute sessions depending on the needs of the individual. So we base the session time, and it's usually one time a week, based on the needs of each person, because every person that walks in through this door is different.
Mhm.
Yeah.
Yeah. Sorry. And then lastly, what would a therapy session look like? I know it's kind of tailored and has to be customized, to the needs of the child, like you had mentioned, but I mean, maybe based on what I'm saying, what would a therapy session look like?
So it sounds like it would be more play-based. So we would use, sounds like it might be more language, and even if it were speech sounds, we still do play-based therapy, which that means is we're playing a game or doing something that, for example, if we're working on plurals, I'd be grabbing like sets of different things, cups, hats, socks, and we'd be playing with all these things, and I would be modeling the plural of each of these like 1,000 million times, because modeling is how they hear it, and then asking the child questions so that they're producing that as well, and then rephrasing it if they're doing it incorrectly. We use a lot of strategies in which the child thinks they're merely playing, but we're really playing with purpose. And the purpose is based on what they need to do. So that would be after the first few minutes of a child warming up, and we greet them, make them feel comfortable. 25 minutes of therapy, and the last 5 minutes, if the mom or dad or the nanny, let's say our
Guardian.
guardian are not in the room, then we would bring them back and we'd review what the session is about, and give them homework that they can do in their daily routines, because children learn best in their daily routines. Like, we're giving them therapy, and we're providing you with the tools, and we're modeling for you and your child, but really the work is at home, because you see them 24 hours a day, 7 days a week. So using our tools to help you, you're able to model the same things.
I like to call parents our co-therapist.
Yeah.
Yeah, no, that's great if we can work together. Yeah, definitely want
Oh,
to
you absolutely have
do
to.
that.
If you dropped off your child for 30 minutes and we worked on it, he'll be like, I'll be hanging out at their wedding. So
Yeah.
we don't want that to
Yeah.
happen.
Yeah, okay. No, thank you.
Want
Thank
to get
you.
people caught up, feeling good and happy with their, their growth.
Yeah. Okay. Would my son be able to be like have you then as his therapist?
It would probably be me, yes, because
Okay, great.
she
Mayo.
Yeah.
Yeah.
It would
Yeah,
be
I'm going to look into the Mayo. I did the early, but then they said that, to be realistic, is a child really going to wear what they're supposed to wear for a long time? And if not, then the early intervention may not work. So,
Yeah, you have to have compliancy for any appliance, and
yeah,
not every child is compliant.
That's what we say in age, like, oh, 4 and upper mile, but a lot of it is like not actual age, but like the maturity of a child matters as well.
You have to
that makes sense.
follow directions,
Yeah.
like higher level thinking directions, and also have the fine motor skill to do it. And
So there's even like a 7-year-old, who like, we have
may
like
not
a
be ready.
4-year-old who is like more ready than the 7-year-old. So it's not always like just age. It's a lot of,
Maturity,
yeah, agree.
attention level,
Yeah.
sustained attention. I mean, you want the child to be interacting and be able to sustain that. Do you want them to sit perfectly? No, we know that. It's never gonna happen.
It's not realistic.
But we have a lot of tools in our toolbox, and we keep people moving, right?
Yeah.
We take breaks, or we do a brain break, things like that.
Okay, great. And lastly, Elaina, do you have a recommendation for an ortho that I can take him to go see for this early intervention? That I might possibly look into.
Yeah, we can contact you after this is done
Okay,
with
great.
some more information about that. Yeah.
Yeah, thank you.
Are you in this area?
Yeah, Ashburn. Right by the metro.
Great. Awesome.
All right.
Maybe we should get to some people. This is being recorded, so maybe some people are going to watch it back, but we want to make sure we answer their questions here. So we have a Megan that wrote in, wants to know about, she said thumb sucking. So maybe I'm going to give that to Mary. She's our thumb sucking expert over here. So maybe she can quickly touch on that. I'm not sure exactly what Megan wants to know about thumb sucking, but maybe Mary can do a quick summary, general
overview
about thumb sucking.
Okay, so the question might be, when is thumb sucking a problem? That's usually the $1 million question. Well, first I want Megan to know that sucking is a normal part of development, right? Children need to suck. They learn how to soothe. They learn to put their tongue up on the palate. And when their tongue is up on the palate, it sends all these feel-good sensations to your brain to relax your overall nervous system, right? And get out of fight or flight. So children can thumb suck, finger suck. They usually start to do it and release that habit between 2 to 4 years old on their own, right? And during that time, you want to encourage the child to use other toys that are more appropriate for mouth play. Like we have, for example, there's a company called Talk Tools, and they have chewy tubes and all different kind of things that are more appropriate to put in your mouth than your fingers, right? And so the child is probably craving some sort of oral sensation, or, the recent development of recent research on airway is that a lot of children, and adults with oral habits, it's an airway issue. So they're using their thumb to anchor their mouth and open that jaw wider so that they have more airway. So that's something to be watching out from 2 to 4 as well. Like if you have a child that's a chronic ear infections or untreated allergies, untreated or undiagnosed allergies, where we're in Virginia and everybody walks around with a chronic stuffy nose. Those are definitely things you need to look at. So at 2 to 4, we're going to give them tools to help them do appropriate oral play. And then by 4 years of age, that habit should have dropped off. And, there's programs that we do at 4. It's more like a gentle reduction and done with the parents as well. And then we have a flagship program for our prolonged thumb suckers, which essentially is 5 years and older. And that's for the children that even have an inkling of wanting to quit, because that's part of it. And B, they're good candidates. So we do a particular evaluation to make sure like there's not something else that's maybe causing that thumb sucking before we expect them to pull it out of their mouth and eliminate that habit. And majority of the time, there's usually something else there. What that may be depends on each person. So thumb sucking is normal, but it should eliminate itself between 2 and 4.
I think that
Okay.
was good.
Sounds good.
And also
I hope
how
that answered the question.
it affects our facial growth and
Oh.
development. Just adding that one in there.
Yeah, definitely. I mean, I was a thumb sucker to the age of 10. Looking back now, I had enlarged tonsils and kissing tonsils. And so every time I would get sick, the doctor would be like, 1 more time and we get those out. And then I guess I grew and I stopped having strep throat every week. But then I broke my nose in 2nd grade, right? So then there went my mouth breathing. And so that thumb served as, and I had a blanket, which on top of it was a trigger, that served a purpose. So I didn't want to eliminate it. And it was really hard.
Our bodies will always adapt to, our structure and everything to keep us alive.
Yeah, definitely. Bodies always adapt to what it needs until it gets the right help.
Yes, exactly.
Let's see what else we have there. There's some information about dysfunctional breathing.
Evidence behind palate expansion. It's kind of like a vague statement. In regards to palate expansion, there's a lot of research out there. If Megan, you want to contact us for some research articles on the benefits of palate expansion, we can send you some articles. The biggest thing we look for as myofunctional therapists in regards to expansion, we want to make sure our tongue has enough space in our mouth. So, yes, we always, or think of, your tongue being your car and your mouth being your garage. If you have a big old Hummer in a tiny garage, there's not enough room. You want, a properly fit garage for your car. So if you have a very, very tiny palate is our upper jaw here. If it's really, really tiny and your tongue is overflowing here, it doesn't fit. Where's that tongue going to go? It's going to fall into your airway. When your tongue falls into your airway, you are more at risk for things like sleep disordered breathing, sleep apnea. So one of our big goals of myofunctional therapy is proper tongue posture, meaning our tongue should always rest up here in the roof of our mouth. But if structurally, skeletally, you do not have enough space, we can't force it up there, right? So that's why we collaborate so much with orthodontist, dentist to create that space, because no matter how much therapy you do, if there is not enough real estate here, the tongue's not going to get there.
Yeah. And we call that structure, right? So there's a lot of terms, Susan, where like function and structure, it can be really confusing. So function is our muscles, and for us, it's the tongue, right? The tongue, the masseters, the lips, those are all muscles, but the structure is
your jaws,
your dental arches,
your teeth,
and your lingual frenulum, which is considered a structure.
Yeah.
So we have to tease out, is the problem a structure? And maybe like, I'll give you an example in a few seconds. Is it a structure that's causing the issue, or is it the function? And if structure and function together, because they're reciprocal. One doesn't work in isolation. The structure and function have this reciprocal relationship. One impacts another, back and forth. And if there is a structure component, we have to collaborate with the correct professional dentist, orthodontist, ENT, and get that taken care of first, because if there's not enough tongue space, which is what we're looking for with that wide palate, then we're going to have a difficult time. But also, an example of a really narrow palate that may have to go to the orthodontist for expansion is a kid that can't produce S, CH, and R, because we need to narrow our tongue to fit it inside our dental arch or close to it when we're producing that speech sound. So that's why maybe you might see a kid who's a little bit of a lisper, or they say the ahs, and it could be a couple things, but that narrow palate can also impact speech sounds. So when we're looking at palate expansion, it's not only tongue space, but is it impacting other things like the suction for the swallow?
Yeah,
the
that
speech
brings us
sound
back to our
production.
function conversation,
Yeah.
speech,
Structure,
swallowing,
function,
breathing,
yeah.
all of, yeah,
Yeah.
brings us back to that. So I hope that kind of answered the palate expansion question.
Yeah.
If you want more information, Megan, just contact
Yeah.
us on exactly what you're looking for. If you want research articles, we can also send you that pertaining to what you are wanting to get answered there. We have Stephanie asking, just said lip tie, more information about lip ties. I don't think lip ties get as much like attention as tongue ties do out there. But lip tie, so we all have what we call a lingual frenum, a tongue, the string under your tongue. That's what people call a tongue tie. We also have a frenum here above our two front teeth that attaches to our upper lip there. When people say you have a lip tie or a lip tie needs to be released, we also, of course, always look at function. It has to impact function. So some things that could be impacting function that a lip tie would cause. If we go to babies, now neither of us are IBCLCs, anything like that.
Nor do we work with infants.
Yeah, nor do we work with infants. But breastfeeding, bottle feeding, those can be impacted if you have
for lip closure.
too tight of a lip tie.
Right.
Mouth breathers, if this is so high up, it's physically harder to close your lips when you have a lip tie. I would know, I do have one and I am getting released.
Produce a gummy smile.
Gummy smile, like
As an indicator.
so. So usually when people get this release, the lip will come down a little bit. Because mine is so tight, it's pulling up really tight on my upper lip there. Also, as a dental hygienist, we look at oral hygiene. So when you chew and food gets stuck up here, we'll see what we call cervical caries. So cavities that form a lot on kids right here. It's harder for them to brush there. The food gets stuck there when they drink or, like sugary drinks or food or brushing. It's all harder to remove right there. So functionally regarding cavities in kids. So yeah, that's a lot for lip tie there.
Well, also in lip tie, so it impacts closure of the lips, period. In terms of feeding, you need to round your lips and close them to drink from a cup. When you're taking food off of a fork or a spoon, we're supposed to use our lips and not our teeth. So if anyone knows anyone that scrapes the fork, the metal fork, they're not using their lips. Their lips are not doing their job. So that's what we'd kind of see
biting
too.
straws. We don't want to bite straws.
That's what we'd see with that lip tie, but also in speech sound development, that can impact the ability to produce the speech sounds that are at the lips. So that's B, P, M, and a W. A lot of times you'll see kids that produce sounds like this. They're using their lower lip is going behind their teeth because pa, pa, fa, fa, fa. Then we start to see that. So it only lip ties, you have to look at the function it's impacting. The spoon, the cup, speech sounds, breathing,
dental,
like the dental cavities.
Yeah.
And then for babies, obviously breastfeeding or bottle feeding. But we have to look at that before we determine. And then we also talk to the dentist because there are some dentists that don't like to release the tie at different times because they're waiting for the permanent dentition.
Yeah. So a lot a lot goes into that. And again, like just reiterating the point, everyone has phrenems. We do not tell anyone just on a picture alone. People will send us a photo. Hey, do I have a tongue tie? I don't know. You know, you have to come in for a full functional evaluation. Like we have to, is it impacting your function? You don't want to just go and do something if you don't have any functional limitations. Right. So that's just really important to remember.
So if your pediatrician, dentist, or the dentist say, can you stick out your tongue past your lips, you're good, that is incorrect. That's not checking how you're breathing, swallowing, speaking, chewing.
So much more to it.
You know, it's so frustrating for us because, you know,
Susan's shaking her head. She's like, yes.
You know, and
she gets it.
That's why we're doing things like this. We want to educate more people and educate more professionals, because if more people knew about this world, we'd be growing healthier faces in airway and health overall.
She's clapping for us. Yeah. And me and Mary, you know, we both went to good schools. We didn't learn anything about this. This is all stuff we learned after our education. Like this is not stuff we got in our like school programs or on our boards or anything like that. Myofunctional therapy.
You have to want to seek, you have to be open-minded, right? Because it does enter the world. I feel it enters the world more holistic, right? Because we're not just looking at like the mouth, the sounds, the language. We're looking at the big picture. I mean, even in our assessments, we discuss food sensitivities and testing for food sensitivities and how that impacts gut health and things like that. And that's some things that are really foreign to people until you start walking in that world. And it usually takes a health scare. But there's more than just the mouth is like the gateway to your health.
Believe it or not, it's screwed on to the rest of our body. That's what I tell my dental patients.
Yeah. So it's really, really important. So,
and I did want to cover, well, first of all, if he watches this recording, shout out to Dr. Eric. He signed up for here, but he's not on. Dr. Eric.
He got on earlier, didn't realize it was 12. So thank you, Dr. Eric. You're great.
Dr. Eric is an excellent provider that we are lucky enough to have in the DMV area, pediatric dentist.
Mm-hmm.
He's amazing. I do want to touch on some people asked about sleep apnea and snoring and UARS. Susan, you briefly mentioned UARS. Okay. So I actually used to work in a dental sleep medicine practice, so I'm all about the sleep stuff. And going back to the full body connection.
Explain what UARS is, though. UARS, for anyone that's listening, is upper airway resistance syndrome. So it's typically your sleep disordered breathing is related to your upper airway.
Susan, did you get diagnosed with UARS? I'm just curious.
It's highly suspected. It's one of those things that it's very hard to diagnose it without actually going through anesthesia, and they do that endoscopy.
The sleep endoscopy. Have you had that study done?
No, I have not, but I had the pattern. I mean, with waking during the night, I think I was going into REM sleep. And that's like a huge clue. And just mouth taping helped a little bit.
Mm-hmm.
Now doing this work and now having room for my tongue to actually be resting on the roof of my mouth is also helping a lot. So I feel like.
Yeah. Are you an appliance?
Oxygen. I have an ALF.
I was going to say, you sound like you have an ALF.
Yes, I do have an ALF.
Okay. How long have you had it?
So I got it started at the beginning of spring. I think it was early 2020 was when I started. And it actually, at first I was doing more, I had severe TMJ.
Yeah.
Mm-hmm.
And so at first they actually the first dentist just really kind of gave me more elevation of my teeth. My teeth grew longer so that this space opened. My hearing actually got better.
Yeah.
But I wasn't getting the frontal piece, the frontal growth or any width either. And so I still didn't have room for my tongue. It was still scalloped on the sides. So, and then I have the hypothyroidism stuff too. So my tongue would tend to be a little swollen anyway.
Mm-hmm.
But probably all the the open, open mouth breathing I had been doing for so long to probably messed things up. So I did have my tonsils out when I was really young, like around whatever that was,
Yeah.
first grade, second grade.
Well, it's not
There's some of the problems. Otherwise, I would have probably been even in worse shape.
right.
But it is starting to move. But it's like, but I was already starting to collapse. So everything's narrower.
Yeah.
But it does now. Once you see it in yourself, you have to be
Get in
careful.
everyone else.
But I see so much mouth breathing now.
Yes.
Right.
And that was actually going to be one of my questions. I know I would like you to answer that, because I guess some other people were asking about URERS and
Yeah.
that.
Let me,
I'll let you talk a little, and then I have just a couple more questions.
Of course. Yeah. Let me touch on, I'm just going to back up here on what is sleep apnea. So sleep apnea, to get a diagnosis of sleep apnea on a sleep study, they look at what's called your AHI score. That stands for apnea hypopnea index. And that is when you lose a certain amount of oxygen. It has to be 10 or more seconds. That's really important. You have to remember 10 or more seconds. And then they count each time that happens as what we call an event. So let's say you had an AHI score of an average of 5 an hour. That's 5 times average an hour in the night that you stop breathing for 10 or more seconds. It could have been 10, it could have been 30 seconds. But that's how the sleep study records it. And then based on that diagnosis, they put you into these categories: mild, moderate, or severe. So 5 to 15 is considered mild, and 15 to 30 is considered moderate. Anything above 30 is considered severe. Now, another important, arguably more important to look at than the AHI score on a sleep study is what we call our respiratory disturbance index. That is called the RDI, and that measures the same thing as the AHI. It just doesn't hit that 10 seconds. So you could lose that oxygen for 9 seconds,
Right.
but that AHI, it's not going to count it, but it will count it as the respiratory disturbance index. So our patients who have a high, let's say their AHI is 1, average 1 an hour, our current medical system would say, congratulations, you're good. You have no problems. You have a 1. That's fine. Maybe like 1 time an hour, you stop breathing for 10 seconds or more. It's fine. But that patient might have an RDI score of like 20 something an hour.
Right.
Who knows? They could have not been breathing for 9 seconds, 20 something times. And that adds up. But our current medical system, and I will say insurance, they only look at AHI, unfortunately. But you really got to look at that RDI, because, and it's more common in women as well to have UARS. And unfortunately, it's like, oh, you're a mom, you're just tired, or they'll say all sorts of excuses there. So yeah, it's really important to look at all of the data regarding that, but that is the big difference of UARS versus obstructive sleep apnea. We have to give a shout out to Dr. Eric.
Thanks for joining us.
Thanks.
We gave you a shout out earlier in case you were going to watch our recording.
All right.
But does that answer that, Susan? Like, does that make a little bit more sense on the diagnosis part?
Yeah, I'm glad you explained it for everyone, because that had been my frustration to realize I probably never would have been diagnosed with sleep apnea, because I don't think I ever stopped breathing for long enough.
Exactly. And also with women, yeah, with women, they say sleep apnea is more common in men than women, but once women hit menopause, we're at the same level playing field because we lose estrogen. So estrogen actually strengthens our airway muscles. So that's why they say women are less likely to get sleep apnea. But once you hit menopause, that's when you see all these undiagnosed UARS women,
a lot of things that
go right into sleep apnea. So yeah, it's a big problem. Like URS definitely needs to be more recognized in our
and the frustration is dealing with people that always insist on going through their insurance to do anything, and they're not going to have any hope
Right.
Yeah.
And not only that, as an adult,
right now.
they send you a home sleep test. So while it's helpful, it's not as accurate as an in lab sleep study.
No,
They do that for adults?
yeah, they record RDI. I just did one. Yeah.
Oh, it's nice to
Okay,
know.
better.
So one of my questions was, if for people who are dealing with this, do you only take people by referral from other health professionals, or can people come start with you if they think they're having tongue
Yeah.
issues?
Oh,
Yeah.
yeah. Us
Right.
people find us on Google, on
Yeah.
anything. Yeah, you don't
We're-
need.
We help everyone.
Because so my friends that are dealing with the mouth breathing, dealing with tongue issues, dealing with the sleep issues, they could start with you.
Yeah. I feel like we're like the quarterback a little bit. They
Yeah.
come to us and then we end up sending them there and then coming back to
Okay.
Yeah, no,
because
it's
we
so
look at the
true.
big picture and then we're like, oh, you need or ENT, or you have, because we do sleep questionnaires as part of our assessment as well. So we do adult questionnaires, we do children questionnaires. So we look at everything, even their posture. Like part of it might be like, oh, you
Mhm.
need to go to the chiropractor or the dentist or a TOTS provider. So I feel like we're the good starting point, and then we quarterback out to where they need to give them the best success. So I think it's a good.
Well, it makes sense, because actually what I've heard developmentally, the first posture that you actually have in your body that that's matures first is your tongue
the jaw.
and the jaw. But anyway, it's this part of your body.
Right. It's your first articulator, but it's also your stability. It's your stability as a very young child.
Where our tongue rests can form our craniofacial growth.
Yeah.
I totally get it. And what's cool, even if you're older and then start to work on this, even though it takes a little longer, maybe sometimes a lot longer, all the still change. In fact, I'm noticing, I think it affects vision too.
Yeah.
Thing in the face. It
So,
just,
yeah.
it's mind blowing, isn't it?
Our orbital eye muscle actually sits on top of our maxilla, our upper
Right.
jaw. So they're right on top of each other. So expanding, the maxilla or changing the shape of the maxilla can 100% affect your eyes. Yeah.
Right. Yeah.
So what type, if someone calls you, then what are they asking for, or they email you, whatever? Like and I'm thinking of friends who have children who like early elementary age up through teens, young adults. I have a couple of my own that I would really give them my own history. I'd love to have them evaluated. I'm trying to figure out what would be a good starting point for them. And
Right.
then friends that are older, in the, my age, dealing with some of these same issues, and women and men.
So Preeti, our office manager, they would call in and talk to her, and she will ask them a series of questions. If Preeti wasn't sure what they needed first, she would contact us to talk about that. We have evaluations, and then if they're not even sure what anything they want, we can also do consultations. So based on what they say their symptoms are or what they have concerns about, we would then do our evaluation based on that. But Preeti is really good at discerning who needs what.
Shout out to Preeti.
Yeah, Preeti's on the call too.
Thank you, Preeti. And then she would let people know then what kind of
Yes, she would give them all
there
the
is, depending on what level of type of investigation needs to be done.
Right. And then it could even change when they come in and walk in the door, because sometimes people don't really like, you don't know what you don't know yet. Right. So, I mean, I have families, they're like, oh no, their speech is fine. And then they walk in and I'm like, oh, I don't think so.
Yeah.
Or we explain, like we start asking questions of case history and they're like, oh yeah, I have this, this, and this. We're like, okay, well, let's talk about that. So it's an investigative process. Every evaluation is so different. We do the same overview of what we look at, but everybody's different. And people that do the cookie cutter approach, I would never recommend anybody going to them saying, oh, we can get it done in 12 sessions, or we can get it done in 6 sessions and you'll be cured. The cookie cutter approach doesn't work for people. I don't believe so.
Everyone's so different. We never,
Yeah.
you just
Some
never
people
know.
need short, some people need longer, but we always update to progress so everybody knows where they are.
Yeah. Now some people they get reluctant because of costs.
Right.
Have you ever looked at ways to make this more affordable? If you know people after they've been evaluated, everyone is different. So I realize, I'm
Right.
but like, hey, could you do some things as group things that once people need to kind of learn how to do certain things, then you could have group exercises, for.
Interesting that you say that because I was just talking to Preeti about that. So we're looking into other ways. And then also as speech pathologists, in addition to myofunctional, we're medical providers. So if you have a PPO, people most of the time are able to get reimbursement from us because we're medical providers, not dentists. But we also, we're looking into other options too. We have care credit too. But we're willing to help out people with what they need.
That's good to hear. And at some point, I don't know what other questions you have, but and maybe this is for another day, but we were talking about, you mentioned genetics, but there's the epigenetic piece.
Absolutely.
Yes. Yeah.
I've been looking at, there's this thing, there might be connection with undermethylation, not the MTHFR stuff, but the DNA undermethylation, like Dr. William Walsh works with, where people, it can be a multi-generational thing where
Right.
you under stressors for so long, so some genes, things have been turned off, or the pyroluria, so you're losing a lot of B6 and zinc. Also,
what you're exposed to,
overcrowding. Pardon me?
what your grandmother was exposed to when your mother was in the womb, and there's a lot of things to
It's a whole rabbit hole.
It is, and I know
You're
my
in
dad
it,
was really.
Susan.
yeah, you're
You're in the rabbit hole with us. It's good.
But it's exciting to know this stuff could change. And then if people will know for even before pregnancy, some things could be addressed and it would make sense.
Wow. I
for the
wish I
kids,
knew all
right?
this when my kids were little.
Oh,
wish
I know, me too.
I even had my kids. Right.
But we don't know what we don't know, right?
So you help those that they don't have to go through what we did.
Exactly. I'm so glad you guys are here and that you set up shop. This is awesome. I didn't know this gift was sitting here.
You can always
Aww.
come visit us too, since you're right here.
Yeah.
All right. Dr. Eric, do you have any questions?
Oh, you guys answered so many good things. I'm just here to support, and I'm lucky to get to work with you guys. So it's awesome to have some educated, like-minded professionals in this area. And I do feel like we've had some great cases together where we saw some
We
really
have.
cool progress. So
Yeah.
for others that end up working with you guys and doing that, I think just getting to see the communication and how awesome it is and how much you guys care about the patients and their progress is really rewarding. So props to you guys.
Thanks,
But we
Dr.
do it as a team,
Eric.
though. It's not just
Yes.
us. That's why we need that's why we have awesome team members like you
Yeah.
that you can reach out to, because we don't do it it's not just us. We have to work with really good providers, and thankfully you're one of them.
Yeah, we are lucky for sure.
Yeah.
Thank you. Well, keep it up. I'm
He
here
took
watching and
care of my
supporting.
own baby. I trust him.
Yes.
That's why I tell my
yes.
patients, I'm like, I let him touch my baby. So
That is a big deal. I appreciate. I'm grateful for that. So thank you for trusting me.
All right. Are you all healed up from your own frenectomy?
Healed, yes, but have I been the best compliant patient? I still definitely have a ways to go as far as
yeah.
stretching things. Yeah, I'll share it on here. Most of my kind of breathing issues though are definitely nasally related. So I didn't have too much restriction like lingually. That was half like maybe it'll benefit with some of the tension. Partly
Mhm.
I wanted to be the patient and go through the patient experience myself.
Yeah.
As crazy as that sounds, I wanted to like be able to speak from a place of experience. But I have a lot of things in I need nose surgery ultimately. I have pretty deviated septum. I have
Oh,
some
you should see
signs
mine.
of upper airway resistance syndrome. So there's
Just talking about that.
yeah. When you were talking about it right now, the different comparing, the sleep apnea and upper airway resistance. I don't have sleep apnea, but I have check a lot of the boxes for upper airway resistance syndrome. So
Yeah, I had it and I had to get surgery.
yeah,
Hours,
I,
8 hours.
think it's in my future for sure. Once I can like, tame some of my activities that I'm into where I'm less prone to maybe getting hit in my face, then I'm gonna probably embark on that path.
Well, yeah,
Gotta protect your nose.
they
I
have
know.
masks.
Yeah, mask. I know the sports face mask. I know. Well, you guys are doing great. I'm proud of you guys and happy for you guys. Keep it up.
Thank
Thank
you so
you.
much for joining on there.
Yeah,
Of
thanks.
course.
All right, are we good? Does anybody else have any
I
questions?
think we answered all the questions that got emailed in.
Susan, do you have any more? We're happy to answer them.
Just a quick summary for people listening. If they're seeing that their kids are mouth breathing or noticing that in themselves, if you could just give a quick summary of just alerting maybe other things to be looking for, things that then become downstream from that mouth breathing, like whether it's attention or whether it's dry mouth cavities. There's a whole, I know you guys probably know it, but maybe you could summarize it.
Well, I think the biggest thing for the preschooler age, 2 to 5, these things you need to address between the ages of 2 and 5. Number one is allergies. Determine if there are allergies and treat them as needed. A lot of parents really hesitant about giving allergy medicine, but then what they're doing is creating, this downward spiral of mouth breathing that becomes habitual and necessary, right? Habitual and then necessary. So for 3 to 5-year-olds, address any allergies.
Nasal hygiene.
Nasal hygiene, which means like cleaning, blowing the nose, putting, some X-Clear in there nightly, have the sleeping atmosphere. But we want to address the allergies, eliminate any oral habits. If you are unable to do that successfully with your child, find somebody who can help you. And then the third one is,
Look for
chewing and swallowing. Make sure your child isn't living on the sippy cup or those pouches. Make sure your children are chewing and swallowing food, chewing a lot of hard foods.
A great resource. I won't go into the depths of it, but it's called Baby-Led Weaning. There's a good book out there. There's a really good parent Facebook page. I did it with my son and I 100% recommend it to everyone. It's basically skipping the puree phase of when babies go from bottle breast to food. And it's all done very systematically. You don't just, you have to cut it up in certain pieces. It's a whole thing, but I definitely recommend looking into it. It is great for proper facial jaw development.
Right.
Could you repeat that again? What was it called?
It's called Baby-Led Weaning. I wish I remember. I think the book is just called Baby-Led Weaning. A good app is called oh gosh, why am I blanking on it now? What is that app called?
I don't know.
I can't remember. There, Solid Starts. That's the app. It's called Solid Starts. And, thank God for technology these days. If you don't want to read a book, you can get on the app and you type in the age, you type in the food. It'll tell you how to cut it up. It'll tell you the serving size. I mean, it's amazing.
Yeah.
And your kid will be, very, very good for their jaw development, but also good for them to get exposed to all those different textures, everything like that.
And one more thing I want to mention too is that if a young child is getting diagnosed with ADD or ADHD, they should also have a sleep study, because a lot of these kids are getting diagnosed with ADD or ADHD and they're finding that the medicines aren't working because the true problem is they have sleep disordered breathing, whether it's, obstructive or just regular sleep disordered breathing. But the symptoms of ADD and ADHD can be mimicked by somebody who's not sleeping and breathing well at night. And, we have a growing epidemic of that with children, and we have overdiagnosis of kids on stimulants. So it should be, ADD and ADHD are a real brain neurological thing. However, they should also rule out there's not something else instead.
100%. Little kids on anxiety, ADHD meds, falling asleep, definitely rule all that out.
So that I think that's important, even though we didn't even touch on that in this talk, but it's really, really important. And for adults, there's a lot of people in this world on the CPAP, not feeling good. Their jaws hurt all the time. There may be another way. They still may need CPAP, but maybe they need less, or maybe we can fix the function so they're not in chronic pain from their jaws. I like you as well, Susan, I had my molars taken out too, because, back in the 80s, that's what they did.
It's all about straight teeth. As long as the teeth are straight, it's
Yank the
good.
molars and make them look straight. So, I had a lifetime airway issues already. That just contributed to the problem. So there's always a way to make your health better. And sometimes this can be the way. So I think that's
Hopefully that answered that.
Yeah.
Sometimes we go off. We're both ADHD ourselves. Sometimes we go in all different directions here.
and maybe sleep, but that's part
Yeah.
of it too. All right. Well, thank you guys for attending. We really appreciate it. I hope you are able to even pull one piece away from this talk.
And if you guys need anything else, those who are watching the recording or here, please feel free to reach out to us if you have any other more questions or need more information.
Yeah.
Oh,
And
you're
that's-
welcome, Jenny. Just chatted.
And that's success@soundmouse.com. And one of us will be sure to answer you.
Follow us on Instagram @SoundMouse.
This is their social media marketer. All right. You guys have a great day and thank you very much.
Bye, guys.
Bye.
Happy Friday.
Bye. Thank you.